Hello everyone, welcome to the webinar today on Cancer Waiting Times Guidance Changes. For anyone that hasn't met me before, I'm Lisa Galligan-Dawson. I'm the Director of Performance for Greater Manchester Cancer Alliance. Today's webinar will probably take around 30 minutes with ample opportunity for questions and discussion at the end. We've got colleagues on the call to support with any technical issues. So if you are having any problems, please drop a note in the chat facility and one of our colleagues will be there to assist you. And if we can ask, please, that you note any comments or questions in the chat as we go along, and then this can form part of the discussion at the end of the webinar. And we might have covered some of the points that you raise in later slides, but that's absolutely fine. Please use the chat facility and we'll pick questions and discussions from there. So moving into today's presentation. The Cancer Waiting Times guidance is changing, and it's changing from the 1st of October. And this is a seismic change really for Cancer Waiting Times guidance. And it moves us from 9 constitutional standards and an informal standard to 3 constitutional standards. The first change is that the 62-day standard, the one that we talk about when we describe how we're doing in cancer. Have you passed cancer performance? It's the 62-day performance that we're often talking about. And that's typically been reported as the classic or pure or 2-week wait 62-day standard, the main one, along with breast symptomatic screening and consultant upgrades. Those metrics are all being merged into one standard, and that will be a target of 85% of patients recorded in time from the 62-day referral to treatment standard. The 31-day standards are also being amalgamated. So the 31-day decision to treat for first treatments and the 3 subsequent treatment standards, subsequent SACT or chemotherapy, subsequent radiotherapy and subsequent surgery. And the standard will be 96% of patients that have a decision to treat within 31 days. And then the third standard will be the faster diagnosis standard, which is already part of the constitutional standards. So the 28-day standard is the third of the standards moving forward. One of the other massive changes is that the 2-week wait standard, which was 93% of patients should be seen within 14 days of their referral into secondary care for suspected cancer. That standard's being retired as of the 1st of October. And the rationale for that is that 2 weeks is too long. The standard no longer aligns with the best practice time pathways or the delivery of the faster diagnosis standard in many of the tumour sites that we deliver. We will, though, continue to record data on first attendance, and this will be reported for management use. And that's because we don't want there to be any unintended consequence of the standard being retired. It's not being retired because it isn't important. It's being retired because it's not fit for purpose, and we need to be using the milestone weights in best practice time pathway as our key markers for delivery. The terminology will also change, and it'll be migrated over a period of time because we're so used to it, from a 2-week wait to a suspected cancer referral, which is actually what our referral forms are called. But I think it's ingrained in us that we class that as a 2-week wait. We love an acronym in the NHS, don't we? And so it does have the same acronym, SCR, as Somerset Cancer Registry. So please do just look out for that when there is discussion around SCR and making sure that we explain whether we're talking about suspected cancer referrals or the Somerset system. Now, in terms of the 31-day standard, I think it's really important to acknowledge a couple of key points on the 31-day standard. It does bring in some additional subsequent treatments into scope, but it also excludes subsequent active monitoring and subsequent palliative care. The rationale for that is that they are quite often on the day of a decision to treat, so would have a 0-day wait and would really skew the figures and quite possibly have high numbers in those areas. The metrics will still be reported individually via our GM systems for the purpose of pathway management, because when you amalgamate all of those standards together, as we deliver the largest proportion of radiotherapy in England, our subsequent radiotherapy numbers are extremely high, and it would be easy for us to lose sight on some of the performance against those other metrics. So we will still report that internally against those individual metrics for the purpose of pathway improvement. For those that are on the cancer management side, the ECAD provision for subsequent treatments is still available. So the standard is for decision to treat, so the point in which the consultant and patient agree that that is the treatment that's going ahead for first treatments is the only clock start for that standard. But for subsequent treatments, there is the possibility of using an ECAD date, which is the earliest clinically appropriate date. So that remains as part of the rules. It's also worth noting that the data that we'll be reporting for management purposes and actually is already available on our GM system. We report that by treatment modality as well, so that organisations and tumour sites can interrogate the data, not just on a pathway by pathway basis, so not just comparing urology, but with the ability to compare pathways that are, for example, urology surgery against surgery, and looking at things like active monitoring separately, so you can really understand what makes up that data. And just delving a little deeper into the 62-day target. So again, this is an amalgamation, so these are not new areas, but for the first time, consultant upgrades becomes a constitutional standard, and the clock will start from the date that the referral is received, or the clock start date, based on the standards for screening to the first definitive treatment. Again, we'll still report these individually for the purpose of pathway management, and that same level of disaggregated data will be available by tumour site, by treatment modality, by first seen trust, or by treating trust. One of the very key things to note from today's webinar is that there is a new in-year target based on the 62-day amalgamated standard. And whilst the target will be 85% of patients treated within 62 days from referral, the in-year target will be set from an incremental perspective at 70% by the end of March 24, with the expectation that there'll be further incremental improvements required moving into the period 24-25. Finally, on the 62-day standard, there is new guidance on when a consultant upgrade takes place. And this is a really important aspect, because consultant upgrades become a consultant upgrade from the point in which cancer is first suspected. So that could be on a referral when it's triaged and somebody spots something within that referral that makes them think, actually, this patient should be on a consultant upgrade or on a cancer pathway. It could be from when a patient presents in a follow-up clinic with the results of a repeat CT scan. It could be when their symptoms change. It could be that they've been admitted to a ward with something like suspected pneumonia, but when they're reviewed on the ward, there is a suspicion that the patient might have cancer, and investigations proceed. The first point in which somebody suspects this patient has got cancer or needs to be investigated for cancer should be the date of the consultant upgrade. What's been added to the guidance is almost a backstop for that, to make sure that patients do get put on an upgrade pathway. And the guidance is suggesting that the very latest time a patient can be upgraded is the first MDT they are discussed at with a suspicion of cancer. So that's the last point in the pathway that patient should be upgraded. So we shouldn't have patients on an MDT being discussed with a suspicion of cancer that have not been upgraded onto a 62-day consultant upgrade pathway. So the idea for this is to reduce the number of patients that are just recorded on a 31-day pathway, to make sure that those patients have parity in prioritisation for diagnostics, that they are being tracked. There isn't, though, the suggestion that if, for example, you run a combined MDT, so you might do a lung MDT with a benign chest x-ray meeting at the end of it, just because the same people attend and the room's already booked, those kind of things. There's no suggestion that if you are just doing benign discussions at the end of an MDT, that those patients should be listed for a consultant upgrade. But it is saying that anybody that you are discussing, because you think they might have cancer, should be upgraded. We don't have many instances, I don't think, these days where we do benign meetings at the end, but just to be really clear that this is designed to support our patients in their consultant upgrade pathway and to ensure that they are managed appropriately. So it's a really important nuance within the guidance. Now, the faster diagnosis standard doesn't change, but it is worthy just of a recap because it will become more prominent. So there are already incremental in-year targets for the delivery of faster diagnosis. The expectation is that we are delivering consistently from March 24, and the standard will be retained at 75% for this current period. There is the intention that in the financial period 25-26, that the percentage target will increase to 80%, with expected incremental improvements through the next 18 months. It is also important to just recognise that the term faster diagnosis is around making sure our patients know the outcome, whether it's a yes or a no to cancer. So the clock stop, if you like, for faster diagnosis is the point in which the patient is informed. So not when we know that a CT scan's been reported as normal, it's when that has been communicated to the patient. If diagnostics are still ongoing, if we don't think it's cancer, but we can't be certain and we need to do more work, then that doesn't stop the clock. It has to be a definitive. The clinicians feel comfortable to say to the patient, you have or you haven't got cancer. I think it's really important as well to recognise that the faster diagnosis standard is not intended to make anybody wait longer to be seen. The reason I mention this is that in some pathways we do have the first attendance, which is kind of a one-stop with a result on the day. So there isn't the intention that we wouldn't now see those patients till day 27 rather than day 14, just because the clock can stop on the same day. The intention is that those pathways are expedited so we can deliver the 62-day performance. Clearly, if we only give an initial diagnostic decision on day 28, we don't have enough time to complete the rest of the diagnostics and treatment in that 62-day standard. So it's really important that just because this becomes more prominent, we don't lose sight on the importance of timely access to appointments and diagnostics in pathways. It is expected as well that there are some pathways where it is easier to deliver the faster diagnosis standard, and the National Cancer Team have announced target levels for breast and skin as 90% as a minimum. And that's because of those things like results on the day. So there is a real imperative for us to retain focus on all of the pathways and delivering those as soon as possible. So what do these changes mean in practice for us? Well, firstly, I think it's a positive change for patients by a refocus on the cancer waiting times, in particular the 62-day standard, and not solely just around reducing the backlogs, which of course are incredibly important. And actually you can't deliver the improved 62-day performance without clearing the backlog. So naturally there will be a retained focus in that area. It does also bring equity to the differing referral routes, which I think is really important for cancer patients, especially as our pathways change and the way in which we see and detect cancer varies. So it's important that everybody that has a suspicion of cancer is visible, is reported against the same standard. I think it is worth noting, though, that there has been some potentially negative patient views that we need to manage. And I think it's understandable from a patient's perspective that the 14-day standard hasn't been being delivered and now all of a sudden it's being removed. And it's quite easy to understand why patients might think that the focus will reduce and that will be a further deterioration. So it's really important that in our messaging to patients, the 2 weeks is too long message does come across. And it's really important that organisationally we don't add to patient anxiety by not focusing on that front end of the pathway. I think it's also fair to say that it's difficult for colleagues in primary care, having been used to being able to say to patients, I'm referring you on a suspected cancer pathway, we're expecting that you would be seen in 14 days. If for any reason you've not heard, please give us a call, almost as a safety net. And in essence, what would you say to a patient now? I think the message that we've been given is you shouldn't really be saying anything different because we're not expecting that front end of the pathway to deteriorate as a result of the changes. But we don't want to equally generate additional work either for primary care by asking patients to contact them in 14 days if realistically they're not going to be seen. So there's some careful work to do around the messaging there. There is going to be an increased focus on different elements of the pathway. So the diagnostic and the treatment aspects of the pathway are going to play an absolutely pivotal role. And I would say surgery is going to be a really key focus. We've not been achieving the 31-day standards, and to deliver the 62-day forms, we need to improve the time to treatment. There will also be an increased focus on the screening and the consultant upgrade pathways because they will become part of the same standard. And at the moment, the backlog that we report nationally and where the standard and targets are relates to those that come from a 2-week wait or a GP referral source, or suspected cancer referral, as we'll now call them, rather than those patients that come from a consultant upgrade or a screening referral source. So it's really important to recognise that there'll be an increased requirement and focus needed on reducing the backlog in those two areas. And so it becomes even more imperative to avoid more patients tipping into the backlog as well, that we have got our first attendance offer correct, and that we do consider the best practice time pathways the key standards for delivery and for monitoring. And finally, on this point, we should recognise that the faster diagnosis standard performance is driven by non-cancer patients in the main. It's an understandable logic, but one that we do need to just point out because it doesn't necessarily mean that good performance on the faster diagnosis standard will lead to an improvement in the 62-day performance. It is an important metric, and it's important from a psychology perspective as well as from diagnosing physical symptoms. But realistically, to improve the 62-day performance, our faster diagnosis performance should be around 88% of those patients diagnosed with cancer. And we are a long way from delivering that at present. So the next two slides, which will come out to you after the webinar today, just give an illustration of where we are at the moment in terms of standards and what that would mean if the new standards were applicable right now. So this is taken from the most recent version of the Cancer Waiting Times performance, and you can see what our traditional and currently reported 62 and 31 day performance is, and you can see the new combined performance. And I think it's a really important snapshot to just appreciate the journey that we need to complete within the period before March 24. So from a 62-day perspective, we've got just under a 7% improvement to make, which is a considerable distance from the standard. You can also see that we will be monitored against FDS. At the present time, we're at 72%, so we've got to get to 75, so 3% away. But you can see that we are required to monitor against the 90% standard for breast and skin. And whilst breast is achieving it this month, that's not been consistent, and skin, we've got around an 18% improvement to make. So again, much challenge ahead for us. And I think it is right that we acknowledge all of the challenges that we've got at the moment. This is certainly not an exhaustive list, and it will be different for different organisations, both in primary and secondary care, and across different tumour sites. But I think it's important to acknowledge that we know that there is capacity challenges. We've got workforce limitations, we've got financial limitations, and we have got competing priorities with elective long waits and urgent and emergency care. We know that we've got the introduction of pathway changes, so additional filter function tests. We know we've got diagnostic challenges in terms of wait times for first line and specialist diagnostics. And of course, we can't ignore the current pressure on industrial action, and not just the activity that we step down, but the activity that we don't book is a really important aspect, which is much harder to quantify. And the cancer-related activities that don't form part of an appointment or a surgery, things like MDTs, PTLs and administration. So we can't ignore the challenges, but equally, for us, if it was our family or friends, we would want the absolute best for patients that are suspected of having cancer and those diagnosed with cancer. And so there are still things that we can look at. There are still things that we can do within existing resources. And I'm not intending to go through everything on this slide now. And like I said, the slides will come out to everybody. It's more of an aid memoir than anything, a list of things to think about when we're discussing how we deliver our pathways. What is it that we could do? So thinking about whether we have 10 appointments on a Wednesday and whether that might be better to deliver 3 appointments on a Monday, 2 on a Tuesday, and some later in the week, those kind of things, to really interrogate what our pathway looks like and what that first offer is in much of the focus. So does that first attendance come with diagnostics? Does a patient come to the first appointment with the diagnostics already completed? Those kind of things. So I think it's good that we do have some focus on those improvements, and I've tried to simplify this into 3 key areas. We haven't got any magic wands to wave, no silver bullets, no stopping everything else just to do cancer. We have to live in the climate that we're in, but the 3 key areas that I believe will give us the biggest bang for the buck, if you like, is the first offer, surgery, and first-line diagnostic waits. And so in terms of that first offer, I've just discussed things like the frequency of meetings, frequency of clinics, or the attendances. But I think that there's some really important aspects in how we deliver those as well. So what's the output? How do we know that we've got the right output from those attendances? If a patient needs to go on to a next diagnostic, is that arranged before the patient leaves? Do we know how quickly that's being delivered in the pathway? And already from that first attendance, we should be considering when that patient needs to go to an MDT and what would be needed to get that patient discussed with the right information. It is really important as well to think about things that don't involve the clinical aspects. So what about the administration? How do we make sure that the right information gets to the right people. And how do we use data to deliver improvements? And for me, looking at the like the distribution of first attendances or faster diagnosis is a really key area for everybody. And the chart that's embedded here is just one of the examples of the types of data that's available on the GM system. It's underpinned by Tableau and used through Curator. But you can see this at organisational level, at pathway by organisation, and in all different cuts of the data. But this shows you the distribution. So it tells you the big line is the standard, and it shows you how many patients are seen before and when, and how many patients are seen after and by how long. And we don't want to see the tail on the right hand side, the purple areas. They are patients waiting much longer than the standard. And equally, it helps us determine what the improvements might be. So you can see in this example, there's kind of 3 spikes in there, and that would suggest to me that there's perhaps a weekly clinic. And actually, could we pull that further forward by delivering that in a different way? Surgery is a really important part of our pathways. So the information that we've got here is basically the treatments that we are delivering on a weekly basis and our surgical waiting list for P2 patients. So whilst we know that from a cancer perspective, there is a 31-day standard from decision to treat to treatment, there is a 28-day clinical criteria standard that was introduced for all P2 surgeries back at the start of COVID. And what you can see on the left-hand side is that we fluctuate and there's variation in how much surgery we deliver on a weekly basis. The red line is the target level that we need to deliver to start to improve and maintain the waiting list. But that needs to be delivered consistently on a rolling average basis to be able to manage the waiting list. And the right-hand side, you can see the waiting list over a long period of time. This is just the P2 waiting list. But what you can see is that it's at an elevated level, and it has been now for a number of weeks and months. So we really need to manage and reduce that surgical wait list, and fundamentally we need to deliver more cancer surgery. And then the final slide on diagnostics. We mentioned the importance of milestone weights by each tumour site, and there is a number of reports that are available on the system for you to review by organisational level. We do take a snapshot of the data from each trust each week, but they are averages overall. So the slide that you can see here shows the average wait time for things like CT. This is a particularly good organisation in Greater Manchester, but what you can see is that with the average, it doesn't look like we'll be close to delivering those milestone weights for the best practice time pathway. And actually, when you disaggregate that data, the CT wait averages at 5 days for some tumour sites and 20 days for others. So the devil is in the detail with everything when it comes to cancer. So it's really important that you consider that with the way that you use data, the way that you use the data that's available through the GM systems to inform decisions around pathway improvement. And again, some of those other reports on there, and purposely, I've not included site names on here. I've just shown one organisation against the GM average. But within each of the pathways, we can measure the average and the median wait times for an intervention on those pathways, and we can compare tumour site to tumour site, but we can compare tumour sites with each individual organisation. And whilst we do get differences when it gets to the point of treatment, so we might have, MFT that does specialist head and neck, that might not be the same wait time or workup to thyroid surgery done in one of our more local hospitals. But actually at the front end, when those patients come through the door, they near enough all follow that same diagnostic pathway. So there is much that we can learn from how other organisations are working and whether pathways or organisations sit as outliers. So please do use the data that's available. It's there designed to help you. And that's the end of the webinar today. We don't appear to have any questions in the chat. So I don't know whether there is anybody on the call that would like to come in and ask any questions. I'll pause for a moment in case there is. Oh, we have got some questions in the chat. I do apologise. Right, okay. So Susan asks, will previous data be mapped to the new standards to allow like-for-like analysis, or are we starting from scratch? No, we have already created reports on our Tableau system, and we've used the published cancer waiting times data, and we've changed the way, because the data's still the same, it's just how we report it. So we can go back now to the start of data, really to see those comparisons. So we do have the detailed comparisons on there already. And then with regard to the in-year target of 70%, is this a GM aspiration or is it nationally set? This is nationally set. So every chief executive has been written to, and within the document that came out, the cover letter, if you like, with the set of standards, the standard is that we're to deliver 70% in year. So that is a nationally set, not just a GM aspiration. Dawn asks, for district hospitals where not all cancer treatments are offered, will we be penalised for treatment times not in our control? So Dawn, this is an interesting one. I don't think so in the main. The way in which the cancer allocations work hasn't changed, even though what's included in the metrics has. So we will include metrics for screening and for consultant upgrades, but actually the way in which we attribute the performance doesn't change. So at the minute, if you are in a district hospital and you refer out to a specialist centre for the treatment, if there is a wait for that specialist treatment, that obviously in the majority of instances means that we don't deliver the 62-day performance. So we've got two aspects to that really. There is a target for delivery of the diagnostic element of the pathway up to the point in which a patient is transferred out for treatment. So that is a 38-day standard. So as a district hospital, if you have completed all of your diagnostic workup that's required for the sector MDT, you've discussed the patient at the sector MDT, and that patient has been referred out by day 38. If that treating hospital doesn't deliver the treatment in time, then they will take the performance breach. However, if you send them out late, so you send them out on day 50 for whatever reason, you've had a delay in CT or they've needed another test, there is an incentive for the treating hospital to ensure that that patient still receives timely treatment. And if they don't deliver the treatment, then within 24 days, they would take half of that performance breach. So in essence, you would still only receive the penalty, if you like, the diagnostic element of the pathway. So hopefully that helps to explain that it is relatively fair. Difficult in some pathways than others, but it's relatively fair. And actually, from a district hospital perspective, the best thing you can do if you're focusing on performance is sort out that very front end of the pathway. Okay, Rashima asks, what do you mean by P2 patients? So the national team, and not just the cancer team, the NHS England issued guidance back in COVID around the prioritisation of patients. So the I guess the standard was that there was P1 patients, P2 patients, and they were kind of life and limb, needed to be done within 24 or 78 hours. P2 patients where clinically it was agreed that a patient waiting 4 weeks was acceptable but not longer, and then P3 and P4, and then 5 and 6 patients. And I guess that the intention when this first came out was that it allowed us to focus on clinical priority, to make sure the right patients got the right access to treatments. And Reshma also says that we do have preset messages to pass to patients with, do we have preset messages to pass to patients regarding expectation of waiting times? We don't at the minute, and I think that's because in different organisations and different tumour sites it varies, and it varies day to day and week to week, and I don't think it would, I think we would create an industry of trying to make sure we checked the time before we set it. So we do need to make sure that we've got something generic, and actually we want to deliver high quality for our patients, and I think our focus does need to be on reducing that front end appointment. I hope that the questions and the answers that I've given to those questions are helpful for individuals. I can't see any others bobbing on the chat now, so I propose that we draw this session to a close. I am very, very happy for individuals to contact me direct if there is a question that you think about afterwards, or something that you don't want to ask on a wider webinar. Please do contact me directly, and the team will send out the slides, that we've used in today's webinar. Again, if anyone has any concerns or queries around the GM data, please do forward those to us, and we can help you. Thank you everyone for attending. It is really appreciated. Thank you. Bye-bye.